Welcome, everybody. You've made it to Best Practices in Blood Resuscitation for Acute Trauma and in Disasters. My name's Craig Jabley. I'm from Emory in Atlanta. I'm going to be your moderator today. I want to acknowledge that the webinar is presented by the Region 1 RDHRS in collaboration with RESPECT, and both programs are funded through ASPR, which is through the U.S. Department of Health and Human Services. With anything that's federally funded, just want everybody to know that the content here is presented by the individual speakers and doesn't represent or reflect the policy or position of any branch of the U.S. government. I want to introduce our speakers real quick. First up is going to be Dr. Eileen Bulger. Dr. Bulger is a professor in chief in the Division of Trauma, Burns, and Critical Care in the Department of Surgery at the University of Washington, where she also serves as the chief of surgery and the surgeon-in-chief at Harborview Medical Center. After Dr. Bulger, next up is going to be Dr. John Kramer, who's the chair of pre-hospital blood transfusion and an adjunct clinical associate professor in the Department of Emergency Medicine at Western Michigan University. And then last but not least is going to be Dr. Ben Scott, who's an associate professor of anesthesiology and critical care at the University of Colorado, where he also serves as the co-director of the Surgical and Trauma Intensive Care Unit. A few learning objectives. We're going to review the best practices and current principles of blood product resuscitation and acute traumatic injuries. We're going to discuss recent advances in the pre-hospital administration of blood products for major traumatic injuries. We're going to identify challenges in the effective mobilization and administration of blood products for mass casualty incidents. And then lastly, we're going to present potential regional solutions to these different challenges.
All right, well, good morning. Really an honor to be here today to talk about a topic near and dear to my heart, and that's the resuscitation of trauma patients. And I was tasked with objective 1, which is to think about or sort of level set us with what the current best practices are and the principles are for resuscitation of acute traumatic injuries. And this has absolutely evolved over the course of my career. And I'll talk a little bit about that evolution because I think it's critically important, because some of the changes that we've made and the advances that we've made have led us to this space now where we can start to think about pushing these products into the pre-hospital space and what that means and how to do it. So it's really an exciting time, I think, in the resuscitation of trauma patients and thinking about this holistically. So these are my objectives. We'll talk about a little bit about the difference between whole blood and component therapy and where the data is relative to those approaches. Talk a little bit about some of the logistical challenges in implementation, and I think a lot of this will come out in our discussion because I think that's what a lot of people are thinking about right now. It's how do I actually do this in my community? And then I think it's important as we go through this to remember that everybody's in a different context. Different systems have different pre-hospital resources, may or may not be able to accommodate this type of program. And most of the data I'm going to share is in-hospital data. And so, the pre-hospital data is still very much emerging. And then I think, again, depending upon where you're listening to this from, most of the context that we're talking about is in high-income countries where there are a lot of resources. This is going to be very different if you're in a lower resource or perhaps a very rural environment. Next slide, please. So the problem is that I think we all know that hemorrhage is a leading cause of preventable death after injury. And we see this day to day in our trauma centers. The trauma chain of survival is really critical. Every step in that chain, from the first bystander that interacts with this patient all the way through to their long-term recovery is critical. And the phase that we're talking about today is that really acute resuscitation phase. So when we're in the process of trying to control bleeding and manage bleeding, we really need to think about, how we manage our blood products. The median time to hemorrhagic death for these patients is 3 hours. So the clock is ticking from the moment that they are injured. And the earlier we can start that resuscitation process, the better. And of course, the first professionals that encounter these patients are our pre-hospital providers. So our goal is to really minimize the time to hemorrhage control, get them to the right facility, the right place to control that hemorrhage, at the same time supporting them with blood products. Next slide, please. So this is a case I took care of back in 2005. A gentleman who was stabbed in the right upper quadrant, came in with the knife still impaled, had really devastating injuries to the liver, the small intestine, massive hemorrhage. And at the end of the operation, I looked down at the floor, and this is what the anesthesiologist had given him, a Herculean effort, right, to give him blood products. You can see there also a whole lot of crystalloid. And that was the practice back in 2005, was a lot of crystalloid along with our blood products, and that has dramatically changed. Next slide, please. And what we're trying to manage, this is that same patient post-operatively in the ICU. You can see he's so swollen, can't close his abdomen, we can't close his chest. He's got massive edema everywhere from his resuscitation. And he's alive, but it's still a really difficult situation because we're in this what's called the bloody vicious triad, or this circular problem of coagulopathy, acidosis, and tissue hypoxia that result from and tend to feed ongoing hemorrhage. And so as we think about our resuscitation strategies, our goal is to really disrupt this triad as early as we can. Next slide, please. And the concept of trauma-induced coagulopathy has undergone, tremendous amount of research, a lot of great basic science to help us understand the pathophysiology, and clinical studies that have shown us that up to 25 to 40% of major trauma patients are coagulopathic when they hit the ER door. So we're already behind in our resuscitation when we first encounter them in the emergency department. And those patients who present that way obviously do much worse, and they have about a 4-fold higher risk of mortality. So anything that we can do that starts to address coagulopathy early probably makes a difference, and that's, again, why some of these things are starting to push into the pre-hospital space. Next slide, please. So a couple of definitions. I think it's important for those who aren't in this space a lot, the terms that we use. So when we talk about component therapy, we're talking about combining blood products that are administered rapidly to the patient to try to resuscitate them. So that's adding packed red blood cells, plasma, platelets together, sometimes cryoprecipitate. A balanced resuscitation is the concept that we're trying to do that in a 1-to-1-to-1 ratio. So we want to achieve as near as we can to what they're bleeding by giving, for every unit of red cells, a unit of plasma, and then platelets in a reasonable ratio. So they come in packs of 6. Right, so 6 units of red cells and plasma would usually accompany a unit of platelets. And that 1-to-1-to-1 strategy, I'll show you some data, has been studied and is shown to improve outcome. But think about the logistics of that, right? Certainly hard to achieve in the hospital, even harder to achieve that in the pre-hospital setting, trying to manage all these different components. One of the major advantages we have, and I'll talk about this data as well, is the resurgence of whole blood. Whole blood's been around a long time. We used to use it back when I was a resident. We had modified whole blood. It's cold stored now, leukoreduced, low titer, group O, Rh positive generally blood. And the data is showing us that we can achieve basically a 1-to-1-to-1 by giving whole blood, and it's probably better. And that all opens up huge opportunities in the pre-hospital space if we have access to whole blood, because imagine instead of trying to give 3 bags of stuff and manage them, temperature control them, and all those sorts of things, you're giving 1 bag. Next slide. So this is some of the data from the PROPER trial. The PROPER trial was a randomized controlled trial conducted in many centers across the United States. We had the fortune of participating in this trial, which really randomized patients to a 1-to-1-to-1, that tight ratio that I talked about, balanced resuscitation, to what was more common practice at the time, which was 1-to-1-to-2. So for every 2 units of red cells, people would give a unit of plasma. And you can see that there was a survival difference. And this really has, I think, changed our practice, has pushed our trauma centers to really overcome the logistics of doing a 1-to-1-to-1 or balanced resuscitation. Next slide, please. But here's the difference. So, when you donate a unit of blood, you're basically donating whole blood. And what happens in the blood bank is they fractionate it into its components. The reason they do that is because cancer patients and many patients don't need the red cells. They just need the plasma, or they just need the platelets. And so for years, blood banks have been fractionating blood that's donated into those component products. But when you do that, there's always a little bit of dilution that goes along with that. So if you look at a unit of whole blood, which has about 80% plasma, it has 212,000 platelets, and it has a hematocrit of 35, that's pretty good. That's kind of what you'd like to give your patient. When you try to rebuild it with component therapy, it's still not perfect. right? Because there's dilution in each of those bags, you're getting about 65% of the plasma, about 90,000 platelets, and a hematocrit of about 29%. So if you think about from the bleeding patient standpoint, what they're bleeding is whole blood, what we'd like to give back to them is whole blood. And that's why there's a lot of push for whole blood in these patients, because it's probably better, not only logistically, but also in our ability to maintain that balanced resuscitation. Next slide, please. So there is emerging evidence to support whole blood as a primary resuscitation strategy. The data is challenging because most of them are not randomized controlled trials. Most of them have been observational studies, and most patients get a combination of both in the hospital because there's a limited supply of whole blood. So they get whole blood up front, and then you end up continuing with conventional therapy if you have to give a lot of transfusion. But nonetheless, there was a meta-analysis done in 2023 that suggested that at least this strategy results in overall reduction in the amount of blood that needs to be transfused, but it didn't find a difference in mortality. There have been some other studies, particularly in pediatrics, that are starting to show some potential survival advantage. And there was a large analysis of the trauma quality improvement data of the American College of Surgeons that was done, again, looking at this, where there was a reduction in mortality. So I think we're still trying to sort out exactly the impact, and there are randomized controlled trials ongoing right now. I know we're participating in them here to really fully understand the impact of whole blood. But nonetheless, it is probably better and certainly at least as good as component therapy. So when we're thinking about the pre-hospital space and the logistics of that, I think whole blood is the way to go. Next slide, please. So I think there's one slide missing, but basically to summarize what I think the best practices are in 2024, as opposed to 2005. It's about identifying the patient that's bleeding early, getting them to the right place to control their bleeding, and doing interventions to control their bleeding in the process. It's starting blood products as early as possible and aiming for either a balanced resuscitation or whole blood or a combination of the two. And then minimizing the crystalloid. I showed you that picture with liters and liters of crystalloid. We have learned that we can minimize that crystalloid, then their postoperative complications will be much less as well. So thank you for that. I think that hopefully that sort of tells you where we are in the field. Looking forward to the subsequent talks, which will focus on more challenges in the pre-hospital and disaster environments. And then we'll be very excited to entertain your questions in the discussion. Thank you.
Thank you, Dr. Bolger. I'm going to pick up from there and talk about some of the EMS aspects of it, and appreciate all the support that you individually, the College of Surgeons, and a number of other disciplines have provided as EMS pre-hospital transfusion programs have been increasing. You'll see here the general comments that I'm going to make in various categories. I want to spend a minute talking about EMS 101, just to sort of level set things, because we're still finding that in the blood community, in the critical care and public health community, there still are some misconceptions about EMS that I want to level set for just a second. Then we'll talk about the challenges, including scope of practice, some reimbursement issues, and how EMS agencies have so far been able to address those challenges to develop successful programs. The next slide, having to do with the EMS 101, will just sort of put things in perspective in that, if we can move to the next slide, please. EMS, in distinction from typically police services and fire services, EMS is not considered an essential service throughout the United States. In fact, in only 13 states is EMS considered that essential service, which allows the EMS agencies access, if the community agrees, to more financial stability, getting financial support specifically from the community. EMS agencies have to depend across the board on reimbursement from transportation services that they provide, which is a problem. In many rural areas, volunteer services rely on community donations, and we say that there are still pancake breakfasts and chicken dinners for EMS services. That is very real across the United States. One of the other things that folks have a misconception about is that there is federal oversight and federal control for EMS services. That is not the case. EMS is regulated at the state level to define scope of practice and the care that will be provided by the various EMS clinicians. We have 4 levels of clinicians that are out there taking care of patients on a daily basis: emergency medical responders, emergency medical technicians, advanced EMTs, and paramedics, all with increasing levels of scope of practice sophistication. As we're talking about blood transfusion programs in the field, it really is limited to paramedic level clinicians at this point. And the level of agencies likewise varies. There are many first response agencies, particularly in rural environments, that respond waiting for the basic life support or the advanced life support ambulance to show up. Likewise, on the next slide, and I'm going to mention this just very, very briefly, there are a number of, go back a couple if you would please, one more. A number of model deliveries that occur within the United States. Some are public safety based, most typically in the fire department, but there are a lot of community third service agencies, which are standalone EMS agencies. Some law enforcement, although that is becoming less and less. Hospital-based, private not-for-profit, and private for-profit. And as I've alluded to, a lot of volunteer agencies around the country. 75% of EMS services are provided by volunteer agencies. So on the next slide, we'll start to look at some of the major challenges that pre-hospital transfusion programs face. First is scope of practice. There is a national scope of practice model which serves as a guideline for the EMS community, but it is up to each individual state office of EMS or whatever the lead agency is in the state to specifically define the scope of practice for their 4 levels of clinicians. One of the challenges that we have is that there are currently, since this slide was developed, 3 more states have come on, but there are currently only 39 states that allow for initiation of field blood transfusions. So that's an issue that we have to address in the not included states and territories that currently don't allow field transfusions. They're working very aggressively on that, and we're expecting that the additional 12 states, including the District of Columbia, which now does allow it, will be addressing those in very short order. But it is very much up to the state to determine whether field blood transfusions can be included in their paramedic scope of practice. Reimbursement is a significant issue for EMS agencies. I alluded very subtly just a minute ago to EMS reimbursement being tied in with transporting the patient from point A to point B. That still is the case for most federal, state, and private insurer agencies. If an EMS agency doesn't transport the patient, they don't get reimbursed for it. Currently, the agencies that are conducting transfusion programs are funded either through grant programs, through foundation donations or things like that, or out of their operational budget. So the cost of developing the infrastructure to conduct a field transfusion program, the cost of blood and the additional components that are required to transfuse the blood currently are not reimbursed by most insurance programs. CMS over the summer proposed a regulatory modification that would include reimbursement, or that would incorporate low titer whole blood into the ALS2 bundle. So there would be an opportunity for folks to include it as part of their treatment care bundles. But CMS was very specific to say this doesn't include any additional reimbursement. So a number of the national organizations are Pre-Hospital Blood Coalition, the College of Surgeons Committee on Trauma, the American College of Surgeons, have provided comments back to CMS to suggest that, candidly, it should not only be limited to low titer O positive whole blood, it should include all approved blood components, O negative, packed cells, plasma, and other blood components. But you also need to address the issue of reimbursement, because currently EMS agencies that have started their blood programs are assuming responsibility for the cost of those programs with no reimbursement additionally provided. And then the availability of blood components. As Dr. Bolger mentioned, we all agree that the use of whole blood is the ideal resuscitative fluid for patients who are in hemorrhagic shock. As the folks in the blood bank community will very quickly offer caution, we still are experiencing blood shortages in many areas of the country. And there are areas where the blood suppliers will not be able to provide EMS agencies with whole blood. So as EMS programs, we need to understand the fact that if we can't get whole blood, then if we can get red cells and plasma, that's an acceptable alternative, less than ideal, but is acceptable. If we can only get plasma, again, that is helping to address some of the issues that the hemorrhagic shock patients are experiencing. Not the ideal, but additional therapy that we can offer that helps. One of the other things that we in the EMS community are working very closely on is trying to address the increased need for blood and blood components that field programs are now generating, and assuming responsibility for helping to work with the blood community to sponsor additional blood drives, to increase donations to the blood pool, whether it be whole blood or component therapy. The next slide shows you just very graphically and very briefly the states that currently allow pre-hospital blood transfusion initiation. Those are identified in red. The ones in black don't yet allow that, and we're working to try and address those issues. The state of California last week actually approved a pilot study for 5 counties, 6 jurisdictions in California to start the initiation of blood programs. The next slide will share with you the way we're trying to globally address these. And we have to recognize that this is a multidisciplinary approach when EMS agencies are looking at starting to develop pre-hospital transfusion programs. EMS is very interested and very supportive of developing these. It has to, however, be done in the context of working very closely with the trauma community, working very closely with the medical community, as we'll talk about in a minute. There are pre-hospital indications for other than traumatically injured patients. And it's absolutely critical to work from day one with the blood community so that we can develop these programs in concert with all of those disciplines. EMS agencies have to develop the appropriate protocols and clinical guidelines. I will share with you that there is still a concern in the non-EMS community that EMS folks are sort of cowboys out there that are doing things without a lot of oversight and guidance. And a successful program can't be developed without appropriate clinical indicators and protocols. To go along with that is the education that needs to occur to the EMS clinicians, the paramedics that will be transfusing the blood in the field, to make sure that they understand not only the clinical indications, but they understand the responsibility that they have when transfusing blood into a patient, to make sure that the transfusion occurs appropriately, to make sure that they are looking for any potential adverse reactions. Anecdotally, we're not finding a lot of adverse reactions, which is typical of what the blood community is experiencing in other settings. We need to make sure that the blood is stored in an appropriate manner, to make sure that there is cold storage if you're working with packed cells or whole blood. And to make sure that not only the administration occurs, but that there is appropriate documentation. The administration and transfusion of bloods is very closely documented and monitored by the blood community. And that is totally appropriate. Now, being part of that chain of transfusion, EMS needs to understand that the documentation that they provide is consistent with what the blood community needs to support sharing blood with us, is consistent with what the FDA requires in blood transfusions. There are several models of how EMS is able to get blood from either local blood banks, local blood centers, or regional blood centers. In some cases, they simply have to purchase the blood. In other cases, we're able to establish a rotation program whereby the blood source provides blood to EMS for a limited period of time. If it's transfused within that time frame, wonderful. If it's not transfused within that time frame, then it has to be rotated back to the blood source so it can potentially be provided to trauma centers or other settings that can then use that blood so that it doesn't expire, it isn't wasted. In terms of blood surge capacity, the next slide demonstrates kind of how we look at it very, very simplistically. You know, go back one, please. Thank you. It can be obtained from local blood centers, and as will be talked about a little bit later, when you look at the blood needs of the Boston Marathon, because Boston is so dense with trauma resources and blood banking resources, they were able to address the needs from the Boston Marathon victims from a local response. There is regional capacity. In one of the model programs that we typically look at is the South Texas Regional Advisory Council, which has established a blood program that was very effective in responding to the needs of the Uvalde setting. From the time that event was identified into the first hour, STRAC was able to transport both blood and blood components by ground and air to the local EMS agencies and the local hospital. So there are regional capabilities that come into play. And then from a national perspective, there is a Blood Emergency Readiness Corps, which is a consortium of over 35 blood centers around the country that on a rotating basis build up their stockpiles of blood and blood components such that if a disaster does occur, then through the BERC, national resources can be transported to local areas. The most recent setting in which that was utilized was the cyber attack in Florida a month or so ago, where it significantly impacted Florida blood centers. And the Brook program was able to then transport blood to local areas. Additionally, on this slide, we talk about herein arms. We'll be able to hopefully talk about that a little bit later, but this is based on the military walking wounded concept, where you have pre-identified donors who can be brought into the system on a short-term basis to help with donations. The next slide will show you just very briefly the 35 plus regional centers that participate in the Brook program. Very active. It's an infrastructure that I think, as we're looking forward, we can help identify areas of expanding and potentially refining on that. In the next slide, I want to point out, I mentioned, and the focus of this is on traumatic injuries, and that's extremely important. But we also want to make sure that we address patients who are suffering from hemorrhagic shock from whatever etiology, whether it's postpartum or peripartum hemorrhages. A number of our EMS agencies are experiencing a lot of medical indications, both dialysis patients and GI bleed patients that are benefiting from field transfusions in the EMS environment outside of the hospital. And we want to make sure that it is agnostic to patient age. Dr. Bolger referred to some studies in the pediatric patient. There is still concern that our EMS agencies experience in their communities. Is it appropriate to transfuse pediatric patients? And the answer to that we're finding is yes, it shouldn't be a concern. And as I've talked about, whole blood is the ideal resuscitative fluid, but we have to continue to be receptive and be able to use any of the individual components if that's what currently is available. There are some programs that routinely use whole blood, but when whole blood is limited, they have to transition to packed cells and blood components. And then just the coalition website and my email address if folks have different questions that we're not able to answer on the webinar. I'll transition now over to Dr. Scott.
Okay, thank you. I think my job, as I perceived it, was probably in the end to be a little more conceptual, because I think a lot of the things I'm going to be able to tell you a little bit about what is generally agreed that we should do in general, but how to do it, I think, is still really open for discussion. One of the reasons that's important to have some, meetings of the minds like we're doing today. If you look at the history of transfusion strategies, very briefly to, repeat some of what's been said already. The concept of blood banking was to make our units of blood that are donated go farther. So we split everything up. And then through, particularly our military trauma experience in Iraq and Afghanistan, we've evolved a concept of damage control and goal-directed strategies, which led to a kind of a general questioning of a lot of our trauma practices. And from a lot of that research came this idea initially of what people have called simulated whole blood, which is the 1-to-1-to-1 transfusion strategy. And as Eileen said, there's a lot of data that does improve outcomes and sort of targets the dangerous coagulopathy of early trauma much more effectively. And now we're sort of moving into an era of not just simulated, but actual whole blood. As has already sort of been brought up, that becomes a challenge when we start talking about taking care of mass casualty events or large numbers of patients. So where we are right now is a recognition that that's probably the best thing for the individual patient, but we need to start thinking about how that applies to mass casualty events. Next slide, please. And so really what we're talking about is, a per patient treatment plan. And, what I would argue, as my colleagues have stated, is that we kind of know what to do for the individual patient, which is early blood management, limiting crystalloid, using 1:1:1 transfusion ratios or whole blood when available. But that challenge needs to be balanced against trying to manage transfusions in a population or large numbers of patients. Next slide. So the other thing that I think has already also been brought up, but I'll just point out again, is that a lot of this is context dependent. Mass casualty events may be rare or they may be recurrent, depending on where you are. A lot of the data that has been used to support some of this research work, has come from places like Israel, where there's a much higher incidence of you could call them small but routine mass casualty events. But I think we all recognize in the disaster medicine community that we really need to be taking an all hazards approach to all this. So I just want to point out, and John brought up that a cyber attack, for example, is functionally similar in the potential effects it can have on blood banking. Weather events, pandemics, obviously have brought this stuff to front of mind for many of us in recent years. Next slide. So I think the first question we have is, how much blood are we going to need? How much do we need for per patient in a mass casualty event? And there have been several attempts to try to quantify this recently. In general, they have come to similar conclusions. So the one I'm citing here, in a review of 1,600 mass casualty events in Israel over 5 years, suggested that really only an average of 1.3 units of red cells were needed per patient total. And if you look at more significant traumatic injuries, the numbers obviously, not surprisingly, go up. But in moderate to severe traumatic injury, the sort of mean number of units needed was somewhere between 4.5 and 6.7 units per patient. And other countries report similar numbers. So if you look kind of across the data that's available, it looks like if you think about an average mass casualty event, that your average patient will need approximately 2 to 4 units, and that's 2 to 4 units of packed red cells. And actually, some folks have tried to drill down on component therapy numbers and have found that the need for plasma is around 1 unit of plasma per 3 units of blood, and the need for platelets is around a quarter to a half a dose of platelets. So how that applies to the individual patient is one thing, but I think if you go to the next slide, one of the risks of this is that we actually may sort of dramatically overestimate the amount of blood we think we're going to need. And so one of the risks that's become apparent to the blood banking research world is that the anticipated need may cause problems that are separate from the actual need of the trauma patients that you're taking care of. I use the September 11th example just mostly because I think it sort of sticks in the mind. But on that day, the blood banking system across this country mobilized 475,000 units of blood. And obviously there was a lot of volunteerism, and people wanted to try to do something because they felt helpless. But in the end, for about 4,000 injured patients, only 258 units were given. So if we go to the next slide, I think the problem is that this creates high risk. It creates high risk of error. And a sort of unrecognized problem is that the blood banking staff and the blood banking system is not always set up to manage this kind of perceived demand. So there's a high risk in folks who work in the blood banking system of cognitive overload, of moral distress, because often they're responding to a traumatic event. There's been documented cases of sort of burnout and basically people working in the blood banking system having the same kind of effects, symptoms, and stresses that first responders do and that other healthcare providers do. And so, as I said, even when the actual transfusion volumes ended up being low, there's a lot of prep work and there's a lot of significant, labor that goes into being ready and into preparedness. Next slide. And so if you take these things together, the challenges are that, we have a system. If you look at that BERC slide that John put up, There were a lot of blood banking organizations in the bottom of that, right? So it's an impressive amount of coordination to create that kind of consortium. But if you look at how our blood banking system works, it's quite disparate. There's a lot of variability between hospitals, health systems, state, regional organizations, and then by country. And a lot of the data that we have available comes from slightly more integrated systems and smaller populations. So, as I said, a lot of the data is from Israel, a lot of the data is from the military. Some of the data is from places like the UK that have a much sort of tighter, more tightly integrated national health system. But one of the things we recognize is a need to try to standardize and coordinate as best we can. Another point, I talked about the risk of sort of cognitive load and strain on blood banking. This is also a high risk for transfusion errors. And so the sort of, hair on fire, we got to get this blood ready can lead people to make mistakes. And so it's very important to think about maintaining transfusion safety. First of all, I think the fact that less blood sometimes is needed than you might think should be somewhat reassuring to people that you should not deviate from your protocols. In other words, you should not just say, okay, we're off, we're going off on our own because we just got to get this done. There's still probably time, and the data would suggest, good reason to continue to follow standard practice. In truly sort of, emergent events, maintenance of some kind of sequential record system for patients and blood units is necessary, and some of the systems that respond, and as John knows better than me, and if you're thinking about sort of doing it in the field, there are alternative systems that are proposed. But what's most important is that you do maintain a sequential record system to minimize errors. There's also the need to try to think about triage systems, right? So, trauma triage and mass casualty triage, as a general concept, are fairly well developed. I think triage systems for blood product allocation are less well developed, but sort of urgently needed. And going back to the sort of challenge or the tension between the individual patient who may need massive transfusion versus the population where most people won't. It has been recommended that we think about modified transfusion protocols and mass transfusion protocols rather than setting up fixed ratios. In other words, you should have goal-directed transfusion strategies that depend on the supply of blood, the number of patients, and the kind of patients you're taking care of. But unfortunately, I think in the year 2024, I can't necessarily give you what those ratios should be. What I can say is that we should be talking about them and studying them and working on them. One of the other things that's sort of a truism in disaster medicine is that simulation and annual system testing are absolutely mandatory. You can't have these systems ready to go if you're not routinely, running them and testing them. And then finally, there's been a sort of, recent introduction of a concept of having a transfusion coordinator as sort of a separate defined role in disaster care. And what that means is not just somebody that's in charge of your blood banking system or somebody who's an expert on transfusion, but having a dedicated sort of responder role that is somebody who can sort of specifically take on the role of managing transfusions, making sure that the labeling system and the process is working effectively. In our hospital, it's kind of recommended, and this is obviously only possible for certain events, but it's recommended that you have one blood bank employee for every patient dedicated to that patient. That obviously becomes hard to do when you're talking about really mass casualty events, but the idea of a coordinator is somebody who maybe can carve out a little bit of cognitive space just to take care of that important job. Next slide. So I think the next question is, where do we go from here? And I don't want to just sort of invoke the magic of AI and predictive analytics, but I will say in this slide, there's a lot of interesting work going on in trying to sort of figure out how to do this better. People are trying to come up with, using machine learning, using AI, using large data sets, trying to come up with better predictors of transfusion risk, right? So ahead of time, trying to be able to determine who is most likely to need transfusion ahead of time to try to, more rationally and strategically plan our blood banking and our allocation of blood products. There's some interesting work on trying to use, machine learning to predict blood antigen quantification so that you could potentially have a much safer ability to to allocate blood or to actually assign units to patients based on both personal and regional genetic factors, so that you might be able to more safely transfuse without type and screens or needing the same level of sort of slow processing that we have. There's a lot of interest in looking at red cell age optimization. So we all know that one of the things that's emerged in the trauma literature in the last 10 years or so is that, not all bags of red blood cells, for example, are the same. It depends how long they've been sitting. It depends a little bit on the specific processes and the components, and how the blood was taken. And so people are looking at whether we can, sort of optimize our supply by thinking about which units need to go where. And then similarly, there's been efforts to look at waste minimization, and this group that I cited here basically used kind of an unsupervised machine learning model that ran in the background to try to identify and alarm the system about potential wastage, to look for ways that we may not be thinking about how we're wasting blood. And then in general, sort of on the population level, there are efforts to try to more strategically and rationally do our blood banking supply based on predicting demand, based on thinking about regional variation, and then also having models that might be able to predict what you need for different kinds of mass casualty events. So unfortunately, as I said, I think there's a lot of interesting work and important work going on here. I think like many things in medicine, we again know what we should be working toward, and some goals I think are clear. How we get there, I think, is up to us. And I think, as I said at the beginning, I think, getting together and talking about these things as a group and working to continue to identify a research agenda and think about how we're going to move forward is paramount. So thanks everybody for your time.
All right, with that, I will thank Drs. Bolger, Kramer, and Scott for their excellent presentations. We're going to jump into Q&A here in just a second. Before then, just two quick reminders. Number one, just for all the participants here, don't forget the slides and the recordings will be on the RDHRS website. And if you have any questions, feel free to use the Q&A feature. Just for our panelists' awareness, a couple of the questions that have come through in the chat, I know we've answered in the chat, but those answers may not have made it out to all of the panelists, or sorry, to all of the participants. So maybe I'll just ask the first one here out loud. For all of the panelists, but maybe to start with Dr. Kramer. So if we have a participant here who's interested in developing or interested in partnering to develop the capacity for pre-hospital blood transfusion and doesn't know how to get started, how should they get started? What resources are available to them? How can they begin that journey?
Well, one of the things that we really like to do in EMS is based on the R&D concept, and that's not research and development. That's rip off and duplicate. So, please feel free. We currently have, as best we can tell, a little over 180 programs. I think it's exactly 182 that we're aware of. There are a number of programs in Texas, Florida, North Carolina, and Colorado. Candidly, I think the easiest thing to do, if folks would want to send me an email and let me know where you are, I'm happy to give you specific points of contact. If you're in the Northwest, Seattle Medic 1, for example, in Eileen's backyard, is doing a great program. We are in the process of updating our coalition website. Hopefully next week, there will be on that website an interactive map that will tell you the currently active programs and point of contacts for them, as well as blood centers in various geographic areas that are either currently working with EMS agencies or are interested in working with EMS agencies. So we will have somewhat of a central repository, hopefully next week. Otherwise, please feel free to talk to your local EMS agency and get contacts from them, or send me an email, and I'm happy to put you in touch with folks.
Another really interesting question in the chat here, and I think maybe Dr. Scott, you'd be well poised to answer this. So the question is, if pre-hospital blood is one of these nuts that we can crack, and patients are able to get pre-hospital blood, such that they don't develop coagulopathy later on, kind of piggybacking off of your themes about, minimizing waste. How do you see pre-hospital blood playing into overall blood conservation in traumatically injured patients?
Yeah, well, one of the things I think I forgot to say in looking at the sort of whatever natural history data that's available on transfusion strategies is that the other thing about the fact that a lot of times less blood is needed is that actually a lot of the blood is also given early, right? So if you look, most of the requirement for blood is in the first 24 hours, and that's separate from the data about sort of the golden hour, the importance of early blood. It's just, if you look at what has been given, almost all the patients that get blood get almost all of their blood in the first 24 hours. So I think that at least suggests the potential, both based on that kind of natural history, looking at how the blood has been given, but also if you think about what Eileen talked about the sort of risk of early coagulopathy and the importance of correcting it. I think there's good reason to suspect that giving a small amount of blood earlier is probably gonna save you transfusions down the road. I think some of the data, certainly from Iraq and Afghanistan, does demonstrate that early, very early aggressive correction of coagulopathy is probably important, and that's led to the whole concept of damage control, is that you try to correct, you stop the bleeding, you try to take care of the most emergent threat to life. And you then warm the patient, correct the coagulopathy, and try to sort of improve the physiology before you do any kind of definitive management. And that suggests that the earlier you can give blood to a bleeding patient, probably the better. We certainly know that early hemorrhagic shock is an increased risk factor for things like bad outcomes after brain injury, and in general, patients who are in shock do worse if they're in shock when they present. So yes, I think so. I'm not aware, and I don't know if either of my co-panelists are aware. I'm not aware of any good data yet that shows that has saved blood, but I think there's a lot of reason to suspect that it would.
Yeah, I think that's been pretty consistent in some of the early whole blood studies too, that early administration of whole blood reduces the overall blood that you need to give. So I do think that's a pattern that we're seeing, and certainly as we try to manage this resource that is very precious, that's something we need to factor into those equations.
Well, the concept that we're trying to reinforce, at least in the EMS community, but I think it applies across the board, is that we need to think of this in the context of the time from injury, not the time when EMS arrives or the time that the patient arrives in the emergency department, but we're trying to impact those interventions from the time of injury.
Dr. Bolger, maybe a question for you. I'm going to preface this by saying, Proper was published almost 10 years ago now, and I feel like with every sequential wave of trainees that comes through, people, read the trial, see that there wasn't any difference in the primary mortality outcomes, interpret it as a negative trial. I'm not so sure that's the correct interpretation of Proper. How would you advise clinicians to interpret that trial?
I think it's absolutely the wrong interpretation. So, like any clinical trial, there are multiple endpoints, and that's why I show the Kaplan-Meier curve, because there's a clear difference there, and if you look at the rate of the mortality in patients that died from exsanguination, it was significantly lower. The rate of achieving hemostasis was higher. The challenge with most clinical trials is the impact on mortality is in the short term. And what people then, they survive their hemorrhage and they go on and they die from traumatic brain injury. And we haven't cracked that nut, no question. Like, we need more work on traumatic brain injury, but they survived from their hemorrhage, right? Because we implemented this strategy, whereas otherwise they would have died from their hemorrhage. And so I think, we have to read these studies carefully, not just read the abstract, but read the whole study. And there are several key indicators there in the population of patients that we're talking about that strategy improved outcome. So, a lot has been written about that. I think it has changed practice. I mean, if you look at the major trauma centers in the country, they have moved to this component strategy, but it takes a lot of work to do that in the hospital, to keep a tight ratio like that in a setting where you're doing a lot of other things to care for the patient. It takes a lot of work. And the beauty of whole blood is that it takes that out. Like, you're just giving whole blood. And it's like, all of a sudden it's logistically much more feasible. And that's why I think in the pre-hospital space, to the extent that we can improve the whole blood supply and address some of these challenges, that's probably the product of choice.
One question that just came through the Q&A. We have a participant who's asking the panelists to weigh in about their thoughts on plasma for TBI in the pre-hospital setting.
I don't think we know.
Yeah, I think there, candidly, most of my information is filtered through the trauma surgeons. I think there's significant interest in it. There may be some suggestion that there may be some benefit, but I agree with Eileen. I don't think we know certainly don't know definitively yet.
And there's certainly studies looking at anticoagulated patients who have TBI, and some of the reversal agents that we use in the hospital, so prothrombin concentrate complex and things like that. There's studies going on in the pre-hospital environment around those to see if we can reduce the rate of intracranial hemorrhage progression. But I think there's just not enough data yet in the pre-hospital space to give you a definitive answer.
Yeah, I would agree. I'm also a neurocritical care, boarded person who doesn't practice that much outside of trauma anymore. But in general, I give a talk to the residents almost every month about TBI management. And in general, I lead with this sort of a blank slide that says all we definitively know about managing TBI. I think that, what we know is that early repair of physiology and maintenance of normal is the goal. Again, that's we know what to do. We don't always know how to do it. So I think the data just isn't there to support that. But there's, again, reason to suspect that what we can do to maintain normal is better. I just see TXA popping up. I mean, I do think that's a promising area, and still, again, I would say is insufficient data to really say it's standard of care, but certainly emerging interest in that.
Yeah, there is.
I think that, where we're heading, I guess the interesting thing, this goes back to the massive resuscitation. What we need to figure out in transfusion and in disaster medicine, just like in almost every aspect of medicine, is which of our patients are responders and which aren't, and which patients should we be targeting these interventions to. And I think that's the whole era of kind of personalized medicine and goal-directed care that we're in right now, trying to figure this out, because probably some people really need that one-to-one-to-one, and some people may not. And identifying who is still a work in progress.
And identifying them in a timely enough fashion that it makes a difference also, right?
Maybe in our remaining 60 to 90 seconds, one last quick question for the panel. I think whenever this topic comes up, there's some common themes, right? The importance of early hemostatic resuscitation, technical problems with accomplishing that pre-hospital, lessons from the military. And I think one idea that kind of lives at the intersection of all of these different things is freeze-dried plasma, which is, met with some success in the military, but for a variety of reasons has been very slow to, kind of promulgate into our civilian practice, at least in the US. Thoughts from the panelists on that?
I've been promoting the idea of it for a really long time. It's fascinating to me that we're still struggling with being able to get FDA approval for products that are widely used in other parts of the world, because it does open up opportunities, particularly in rural EMS, in places where you're far away from a blood bank and you can't cycle blood products, and all you've got right now is lactated ringers. To have the ability to give reconstituted plasma in that setting makes a lot of sense. And I think it's just been a real regulatory challenge that I'm not sure. Maybe John's consortium can overcome that as well.
Well, that's one of the things we're looking at. It's interesting that the FDA recently approved an emergency use authorization for the military for a European dried plasma product. It will be interesting to see how they can figure out a way to delay that in the civilian community. I'm a recovering federal bureaucrat, so I understand they'll figure out how to do it. I will observe that there are a number of other dried plasma products currently under research and in development that hopefully will be available in the fairly near future.
All right, well, that's an hour, and I think we'll call it. And with that, thank you again to all of our panelists and to our participants.
Thank you.
Thank you.
Thanks, everyone.